It's interesting talking about age and propofol. We looked at a sedation technique using a brain function monitor with propofol, and this was people, young people, middle-aged people, elderly people, and the anesthesia provider was not aware of this brain signal. We had it blinded, and then we looked back after 100 patients. How deeply sedated were people having an endoscopy procedure, a colonoscopy in this case? And when we look at the slide that's up there, we saw that over 50% of the patients were in deep general anesthesia. So if we had a guide to depth of sedation, perhaps we could save on the amount of propofol we're using, but also once you get into deep anesthesia, there are airway problems, there's airway depression, there are problems related to giving general anesthesia when we really want to just plan sedation. So I think there could well be a role for these monitors in controlling sedation, not just in a critical care unit, but also in a procedural unit as well.
Just to add to that is like, you know, it's like maybe a lot of times we do feel we have to make people a little more sedated than we hope for what we consider a MAC procedure. And well, it'd be nice if we knew we weren't too far in a hole. We know that, okay, we need to get them a little more sedated so we can get the procedure accomplished. But you don't want to go 10 times or 20 times farther than you have to. That way, if you get into trouble, you can back out quicker. If you have to get to the general anesthesia level, that's fine, but it'd be nice if you weren't 10 times beyond that, making this procedure accomplished. Yeah.
Well, you know, we've talked about special populations, and they are so vastly different. Let's talk now about particular procedures.
Well, I think this, to me, is the real bang for the buck for using a brain function monitor, and that is patient safety. And I'm going to show you a few examples of patients where the monitor has really helped in their management. We do a lot of liver transplantation at Baylor, and many of these patients are incredibly sick when they come through to have the new organ put in. They may be comatose from hepatic encephalopathy, and so how much anesthetic drug do they need? And so we put the monitor on all these patients, and in this particular one you can see that the PSI is very low, and this is without any anesthetic to begin with, and then where the green arrow is where the new liver was implanted. And from that point on, you start to see that various toxins get taken out of the blood, filtered out of the blood by the new liver is functioning, and we start to see electrical activity develop, and that patient's brain starts to function again because the liver is functioning. And so it really, here, it was a good guide to graft function. We knew that liver was working from the minute we hooked it up because that brain started to clear, and we had to give more anesthetic drugs to it.
You know, we've talked about using the monitors for a level of sedation. Let's talk now about patient safety. Mike?
Well, as I said a little earlier, I think this is the bang for the buck. I think the first thing I'd want this monitor for is to keep patients safe. And here's a good example. This is a patient who had an aortic valve replacement. And you can see the anesthetic was running beautifully. Everything was in the green up until suddenly you see it drop, and you see that dark blue under the line, which is burst suppression. So, and this was just after we came off bypass. And hemodynamically, the patient's fine. Everything looks good. But when we looked at the aortic cannula, we saw an air bubble. So the likelihood is this patient sustained an air embolus. So we immediately reacted to it. We raised the blood pressure, we dropped the venous pressure, and we believe we pulled the air embolus or drove it through the brain, and you can suddenly see about a few minutes later the brain activity comes back to normal, and that patient did very well. What would have happened if we hadn't had the monitor on? Would we have had the same outcome? And I think that's a question we've really got to question ourselves. I think the monitor here led to an intervention that I believe saved the patient from a significant problem. Here's another example. This is a patient back in the old days before we had smart pumps. Smart pumps, infusion pumps, are those pumps that check how you're programmed, won't let you give an overdose of a drug. But this patient was a heart patient who was being monitored in the ICU, and you suddenly see the power of the trace drop down to 0. And this was a drug overdose, misprogramming of the pump, and that was picked up by the EEG monitor. Another example using what we talked about earlier, this very colorful display, the DSA, density spectral array. And this is where an aortic cannula was malpositioned, and the right side of the brain, which is the bottom part of that trace, you can see the color is a little bit different than there's asymmetry between that and the upper side of the trace, and we just readjusted the cannula and it equaled out. So again, was it going to make a difference? We don't know, but it caused a clinical intervention. And another example is a patient who went into cardiac arrest, and we see the electrical activity of the brain is very sensitive to perfusion. It dropped off immediately. Patient was treated, and you can see they came right back to the level they were before. That gave us a very good prognosis that this patient was going to do well. And finally, a liver transplant patient, another one rather similar to the very first patient that shows an unconscious comatose patient, and the new liver is put in, and gradually the brain wakes up, and you can see suddenly how it wakes up. And without a monitor, that have a few more minutes where that patient is up at 100, and they probably would be awake. So we have many instances where the value for patient safety of these monitors has paid off. Maybe for a last example, a patient who was unconscious in our recovery room after surgery. They were diabetic, and the EEG showed a low number. We gave an infusion of glucose, and the brain recovered. So just shown again how sensitive the brain is to metabolism as well as to perfusion.
You know, neither of you have mentioned awareness during sedation. Do you think that these monitors prevent awareness during sedation?
I think we've tried to stay away from that. I think they're a guide with the other modalities that we have to look after a patient. But we don't really know where awareness exists in the brain. We're looking at the cortical activity, but the cortical activity may be secondary to a brain that's waking up deeper in deeper depths of the brain. An example of that was a paper that was published in Science 2 years ago by Safer, who talked about the on-off switch, that you go from being awake to asleep or asleep to awake as an on-off switch. Those of you in the audience right now who are getting sleepy because you've had lunch may have developed head nods. You know, where your head falls backwards and you nearly break your neck. That's the on-off switch. You suddenly went to sleep. You didn't drift into it. It was a discrete moment in time when you nearly banged your head on the wall behind you. And I think this is where awakeness and awareness comes from, somewhere deep in the brain, and the cortical activity is secondary to that. And we've all seen patients wake up with a relatively low number on the monitor, and then gradually the number comes up. So I think it's more complicated than that. So just to think that they're an awareness monitor doesn't do justice for the depth that these monitors, the other things these monitors can show us. I think we have to just use it in combination with other parameters that we have to look at awareness.
I certainly think that these are a safety monitor. I mean, it's like you imagine the off-on switch of being awake or asleep, you know, and part of the things that puts us in high risk are the things we know that are high risk for awareness from the literature, whether it's the trauma patient, the OB patient, the cardiac patient. And maybe still sometimes in the general OR when you have a malfunctioning pump, the propofol is no longer running, or it's running on the floor, the IV has been obstructed, or the volatile anesthetic is ran dry. And I've seen this, it's been a very early indicator of lack of anesthesia when everything else would indicate that anesthesia was being given. So I still think all of them could be used as a safety monitor to make sure that something unusual has not gone on. And I've seen it as an early detector of when something has gone wrong.
All right, well, that is all the time that we have for today's program. And again, I'd like to thank Drs. David Drover and Michael Ramsay for their contribution on this very important topic. And now from vhatv, I'm Beth Wilson. Thanks for watching.
This program is supported by an educational grant from Hospira.